Hi, everyone. My name is Dr. Esiosa Ighodaro, and I'm a PGY4, and I'll be the senior for your stroke service this month. Stroke service is extremely busy, but hopefully with these videos where I provide tips and workflow, hopefully we can have fun together, take care of patients, and run a more efficient, effective service. So with that, welcome to the stroke service. And here I just wanted to show you a checklist of how I would like for you all to approach patient care. And I think it will help with efficiency and getting our work done. So here's a checklist for pre-rounding. So when you come in every day, sign out is at 6:30 a.m. So try and be here a bit earlier so that you're ready for sign out. First thing you all want to do is get sign out from the overnight resident. After that, distribute patients evenly amongst yourselves and be sure to distribute the workload evenly. So there are a few patients who are waiting for discharge. Make sure that patients waiting for discharge are spread across everyone equally so that no one has too heavy of a workload. And whomever the on-call resident is, that person should have the fewest patients so that they have time to prep for admissions. And after you distribute the patients evenly amongst yourself, then sign on to the stroke service. And when I see you in person, I'll teach you how to sign into the stroke service. Next, you want to stub a note for patients who need a progress note. We'll get the note the day before, copy that, stub it, and then throughout the day, you can make changes to it. After you stub a note, next, go see the patient. I would not do chart review until after you've seen the patient, just from a workflow perspective. What you need to do when you see the patient is to perform the NIH stroke scale on every patient every day. Talk to the bedside nurse for overnight events. After you have that information, then come back. Then you can review the chart, start filling in your note if you have time, and pertinent things that you would need to know for the patients are overnight events. Vitals, biggest thing is the blood pressure. Are they at gold? If not, did we have to give any PRN antihypertensives? Knowing the in and outs, it's really good. Here, just make sure that they're urinating and make sure that they're having bowel movements. Those are the big things that we need to know. Labs, big things here would be stroke labs that are pending. And if there's any other pertinent labs that we ordered from previously. Imaging here, make sure you've taken a look at the CT scans, the CTA head and necks, and the MRI. Those are really important so that when we pull up the images together during rounds, at least you have attempted to look at them and kind of have an idea of what you see. And if you have questions about the images, that's okay. We expect you to have questions. We will review them during rounds. And then kind of have assessment and plan. Biggest things here would be knowing what's the stroke syndrome, what's the mechanism, etiology, and antiplatelet anticoagulation plan. And do we need to do any further etiology workup to support the hypothesized etiology for the patient's stroke? And I'll do a separate video on stroke etiology. And then after that, present barriers to discharge. How long do we expect them to be in the hospital? Are they pending? Are they going home? Are they going to a nursing facility? Are they going to rehab? If so, do we have those up and running? Do they need outpatient follow-up? If so, has those orders been placed? Who's going to see them? So those are the things you want to be thinking about from a discharge standpoint. And again, I'll help you work through that, but I just want you to know that this is what is, these are the expectations for pre-rounds. And then when it comes to rounding, here are the things you should present during rounds. So presenting a new patient is going to be different than presenting an old patient. So if you have a new patient, typically during rounds, you will get the sign out from the on-call resident regarding the new patient, and then you're expected to be able to present the patient from start to finish. So treat the new patient like it's a patient that you had admitted and really try and get as much detailed information from the on-call resident as much as possible, reading the note from the senior and the ED, if they're admitted from the ED or a direct transfer. So you're expected to, present in this format is the format I would strongly recommend. What's the chief complaint? What's the HBI? What brings them here to the hospital? Why are they admitted? What happened in the ED? Really focusing on pertinent labs and really the imaging. And then when they came up to the stroke floor, what was the course on the stroke floor? And then talking about what's their vitals, again, focusing on their blood pressure goal, ins and outs. Are they urinating? Are they having bowel movement? And are they able to eat? Most patients, when they get admitted to our service, we have to do a Gus or Massey to check their swallowing. So if the patient is NPO for those reasons, then are we giving them fluids? Again, really key, do the NIH stroke scale, and I'll talk through how to do that, how to perform that in a different video and also in person. And then after you present the NIH stroke scale, what's the big plan for the day? Really focusing on, actually, let me put this here, assessment. So what's your assessment of the patient? Again, does the NIH stroke scale localized to what we see on imaging? And then if they do have a stroke, what's the mechanism? Do we need to do any further investigations to tease out the mechanism, like cardiac, hypercoagulable state, any other imaging, and then stroke labs. Know what is their anti-thrombotic plan? Are they on anticoagulation? Are they on antiplatelets? If so, what is it and how long are we going to do it for? And then that kind of gets into what's the plan for the day, and also preparing for discharge. So if you present in this format every single time, it makes rounds more efficient, more effective, and we can get through it. And it's just a great way to learn. So that would be my recommendation for new admits. And for people who are old, what I would like for everyone to do is give me the one-liner. What's their stroke syndrome and what did we find on imaging and how long have they been in the hospital? And that's pretty much all you need to do. You can do that in one line. And then next, talk about overnight events and ins and outs or vitals. Again, what's their blood pressure goal? Are they at goal? Or are they too high, too low? Ins and outs, need to know if they're urinating and if they're having bowel movements. And it's important to know that because it could be a barrier to discharge if a patient hasn't had a bowel movement in 3 days, or if they're not tolerating oral intake. It's important to know these things. So just making sure you're keeping an eye on this daily. And if they're not having bowel movements, then we need to, treat accordingly. Again, presenting the NIH stroke scale, presented daily. Any pertinent labs or imaging, if there is, be sure to present those findings, and I'll help you all pull up the imaging so that we can discuss it during rounds. And then what's your assessment? Pretty much here, what's the assessment? What's the stroke etiology cause? And then what's the plan of the day? Really focusing on antiplatelets, anticoagulation if needed, blood pressure medications. Are they going to be on atorvastatin? If so, we're going to do 40, 80, things like that. And then discharge prep. What's the barriers to discharge? Where are they going? And what can we do to help facilitate them getting to a safe discharge? So that's rounds. And then after rounds, here is what I expect everyone to be doing daily post rounds. Again, to keep us organized, keep us efficient, and keep the workflow moving. So as soon as we're done with rounds, place consults so that the consult services can see the patients sooner rather than later. Place all orders that we talked about during rounds, and then also place AM labs if needed. Pretty much the pertinent labs are going to be the stroke labs if they don't have those already. You don't need to place a CBC and a BNP on patients every single day unless there's an indication. And you can talk to me if you think a patient needs a CBC or a BNP the next day. And then after you place all of your orders, consults, and AM labs, then I expect everyone to check in on their patient in the PM. It doesn't matter when, just make sure you check in on the patient, update the patient and their family as appropriate. After that, I want everyone to complete the handoff by 5:30 p.m. so that I can review it before the on-call resident comes in. After the handoff is done, then that's when you want to finish your progress note, updating whatever needs to be updated and have that finished before you leave. And then by 6 p.m. every day, update the hospital course, because that'll be really important so that we can help facilitate people who are discharging the next day. So this is just a checklist. We talked about pre-rounding, how you should approach pre-rounding, talked about rounds, how you should approach rounds, and then post-rounds. And I'll be sending this out to everyone via email. And if you have questions, feel free to let me know. But this is one of the expectations I expect everyone coming in onto the stroke service to do daily so that we have efficiency, we take care of patients, and we run this service smoothly. And if you have questions, let me know. Other things I recommend is here's a really good resource. This is more important for the neurology PGY2s who are moving on to PGY3, PGY4 in neurology. There's this book by Catherine Aben, who I know really well, who's a neuro ICU consultant at Emory, along with one of her colleagues who got together and they wrote this book on the acute neurology survival guide. And I have been able to, I've actually used this book in the ED. I wish I had it when I was in the neuro ICU and on stroke service, but nonetheless, I think this is a phenomenal resource because it kind of does what I did for you all in the stroke service. It basically has how-to guide, how to pre-round on neurology floor, how to pre-round when you're in the ICU, the coma exam, cranial nerves, stroke, how to review CT scans, MRIs, etc. So I strongly recommend this book if you don't have it already. For those of you who are off-service residents, I have a copy of this book that I will be bringing to work every day. You're welcome to view it as well. So here's just one really good resource that I find very helpful, and I recommend the neurology residents to consider purchasing. And I'll have a link in the video where you can purchase. Another resource is I host several neurology study groups. Again, this is more so for the neurology residents who are in the program. You should consider joining the neurology study groups. It's not a requirement, it's just a recommendation. And if you don't have time to join, you can take a look at this website and review past study sessions where we, talk about different things in neurology, including stroke cases. You can check out these videos not only on my website, you can also check it out on my YouTube channel. If you go to videos, you'll be able to scroll through and look at all the different videos that I've done for neurology and some of the really good videos for people on stroke. And this is a video, anyone can view these videos. I did maybe 4 or 5 cases, stroke cases, where we're just going through different kinds of stroke presentations. So you have Ziengbe Neurology Study Group Stroke Cases Part 1, Part 2, Part 3, Part 4, part 5. So I did about 5 videos that talk about different stroke cases, and I would highly suggest, just taking a look at some of these cases so that you understand the thought process of how to go about approaching neurology, stroke cases, and all the things that are involved. So with that, I'm going to end this video, and if you have questions, let me know, and I look forward to working with everyone on the stroke service. Thank you.